So the important gastrointestinal infections which we should know is very important from the upper respiratory tract, that is the esophagitis, very important and often neglected when the students are studying through it, and the Clostridium difficile and the Hepat's disease, a very interesting disease, but also very rare disease. And H. pylori infections, a lot of important things and a lot of recent advances are going on in the particular field. And obviously the acute infectious diarrhea. So I will not be discussing the acute infectious diarrhea, but I have given some important tables and etc. for your revision in this particular slides. So let's start with the question. So try to answer this question before moving forward. There's a 35-year-old male with a past history of AIDS with a last CD4 count of 25 and is presently not on ART. Presents with a 2-week history of burning substernal chest pain and pain on swallowing. That means there was an odynophagia and substernal chest pain. And he received a course of a fluconazole. So despite this, the symptoms persisted, and this particular patient underwent the esophagogastroduodenoscopy, which reveals the following picture. So the question here is, what is the differential diagnosis? How do you confirm the diagnosis, and what is the treatment for this? So these kind of questions do appear in all the kinds of entrance exam, especially the AIMS. The endoscopy pictures are invariably given along with the question. So you need to know how to go ahead with the differential diagnosis. So the esophageal infections are very, very important things which we should know, especially in a patient who is immunosuppressed. Although these esophageal infections are not common in case of immunocompetent patients, these are very, very common in case of immunosuppressed, particularly the HIV patients. But it can occur in some immunocompetent patients also. There are case reports of esophagitis occurring in immunocompetent patients also. So the esophageal infections are encountered frequently in clinical practice. We know particularly in patients with impaired host defense, and they are obviously an important contributor to both morbidity and mortality. So nowadays there is an AIDS epidemic going on, and the increasing use of immunosuppressive therapy for organ transplantation. The organ transplantation has taken a track nowadays. Each and every organs are being replaced by the transplantation in the humans. Including the recent heart transplantation, all these things. So a lot of patients are being there on the immunosuppressive therapy, and the AIDS epidemic being going on. So these esophageal infections are being increased in the incidence, which we should know. So many viruses, the fungi and the bacteria are associated with infective esophagitis, and whatever the organism, the infection results in the mucosal inflammation and a very clinical hallmark complaint of odynophagia. So any patient who comes with odynophagia, who has been ruled out an upper throat or the oral cavity cause, so need to be suspected for the esophagitis nowadays. So what is this odynophagia? This odynophagia is a painful swallowing, and it implies an acute and a severe form of esophagitis, typically with a mucosal ulceration. So odynophagia it correlates with the mucosal ulceration in the endoscopy. So it is a painful swallowing, and it also depicts that this esophagitis is an acute thing, and it is obviously a severe form in the practice. So the experience substernal, the location of this odynophagia is usually substernal. It is not in the throat. So it behaves as an aching or a stabbing kind of pain that is aggravated by the act of swallowing even saliva. So these patients invariably come to you with a typical history of this painful swallowing. Even the saliva swallowing is too much painful. It causes a stabbing sensation in the substernal area. So you need to suspect the patients, the esophagitis, after ruling out the upper ENT causes. So the many organisms are being responsible in causing this esophagitis. So majority of them are fungus and virus, and rarely the bacteria and some parasites. So among the fungi, we know the Candida species, the mainly Candida albicans and other Candida species are responsible for the most common cause of the esophagitis, and other funguses like the Aspergillus, the Histoplasma and Blastomyces, depending on the epidemiological risk factors, have been detected as a causative agents. And among the viruses, it is the mainly Herpesviridae, that herpes virus simplex 1, the cytomegalovirus, the varicella zoster, and HIV per se can also infiltrate the esophageal mucosa, and along with the rare human papillomavirus causing C. cervix. So there are some bacteria, especially the chronic bacteria like the Mycobacterium tuberculosis or the avian complexes and the Actinomyces israelii, and the routine organisms like staph and strep have been detected as a causative agents. But mainly it is the fungi and the viruses is responsible for the causes of the esophagitis. So we should know that Candida esophagitis, the herpes simplex esophagitis, and the CMU encephalitis little bit in detail to answer the questions and to know the routine practice. I think every week I see a patient of the Candida esophagitis. Every 10 patients you order for endoscopy, one of them is going to have a Candida esophagitis, either diabetes or in a patient of AIDS. So it is such a common disease. So among this Candida, the Candida albicans is a very common subspecies of the Candida which has been responsible. There are other non-albicans species also like Tropicalis, the Parasolis, the Cruci, the Glabrata. These are rare organisms. And you know that Candida are the normal components of the oral flora. So this colonization is not unusual. So many of the patients may have the candidal colonization in the esophagus, but this colonization usually does not cause any clinically significant inflammation penetrating the mucosa. This happens only in the setting of effective cellular immunity. When the mucosal immunity has been down in a patient of immunosuppression, this normal colonization of this Candida species is going to progress to a stage of esophagitis. So this candidal mucosal involvement ranges from a scattered white flakes, which may be accompanied by mild or no symptoms at all. And sometimes it can form a dense pseudomembranes, which is consisting of the fungi, slough, mucosa, and fibrin in the patient. So ranges from a very mild disease to a very severe disease. So this Candida esophagitis, if you encounter, you need to rule out an HIV infection first and foremost. This is a very, very important. And among HIV, this is a AIDS defining illness with the CD4 count being less than 200 is a major risk factor for this particular disease. So one of the AIDS defining illness, if at all the patient is having Candida esophagitis in a patient of HIV, he needs to be considered as AIDS. That means end stage HIV infection. Sometimes, as I told you, it ranges from an asymptomatic stage, particularly in an immunocompetent person. If an immunocompetent person is been having a Candida esophagitis, this is usually asymptomatic and may deal with itself without being presented to the doctor. And we know that the most common symptom of any esophagitis is the odynophagia. So this is usually localized to the retrosternal area, and this may not be associated with the dysphagia. We know dysphagia is a very particular symptom of the upper the throat involvement or the upper esophageal masses, all these things. This is very, very common with dysphagia, whereas odynophagia is a very discrete symptom of this esophagitis. And sometimes the pain may be so intense that the patient avoids eating. So there may be a cytophobia in this kinds of patients. And in severe cases, the constant retrosternal pain may also be there. If there is an ulcer present, the pain may not be related to the swallowing. The pain may be constant retrosternal pain, which might have been mistaken for some other causes of this pericarditis or acute myocardial infarction. The patients might have go round into the hospital before diagnosing as a esophagitis. So in a patient of the granulocytopenia, that means the agranulocytosis, the infection may be disseminated, causing the candidial septicemia. And in AIDS, this esophageal candidiasis is usually associated with the oropharyngeal thrush. That means oral cavity and the pharyngeal cavitial candidiasis may also be seen, but this is not a rule. This is a very, very important thing. The esophageal candidiasis in a patient of HIV or AIDS can be associated without involving the oropharyngeal candidiasis. This we should know in particular practice. So what if HIV negative? If you encounter a patient, if you advise a gastroesophageal endoscopy and you see a candidial esophagitis, but if the patient is HIV negative, then you need to rule out some conditions which predispose to the luminal stasis, mainly achalasia cardia and the scleroderma, which causes the intestinal paralysis kind of thing due to reduced motility. And another risk factor is the patient on inhaler steroids for their bronchitis or bronchial asthma or COPD or for any other matter. So these patients on inhaler steroids are exposed to the esophageal candidiasis particularly. So this can be the entrance question in future times. So if a patient of candidal esophagitis is HIV negative, what are the other causes to be ruled out? The most commonly it is the luminanceasis, maybe secondary to echinacea or scleroderma, or the patient may be on inhalator steroids. So what complications this esophagitis can cause in candida? So this can cause an ulceration leading to bleeding. If involving the blood vessel, it can cause an obstruction of the esophagus by fungal ball. It can form the fistula into the trachea, the bronchus, and the mediastinum, or there may be a mucosal sloughing which might present as an hematemesis. So how will you diagnose this patient? So if at all you're seeing a patient of HIV, and if he is having oropharyngeal candidiasis and also presenting with odynophagia, you can directly start the empirical treatment in those patients without even ordering the esophagogastroscopy. So this can be the routine practice. If at all the endoscopy, sometimes it needs a referral to the higher center. Many of the doctors may not be equipped or may not be trained to do an endoscopy sometimes. So you may be dependent on some surgeon or some other gastroenterologist for the endoscopy. So sometimes if you are seeing a patient of an HIV and if his symptoms are pertinent and related to the candidal esophagitis, you can directly start away the empirical treatment. So how can you diagnose this patient? So the diagnosis is mainly based on the endoscopy along with the directed brushing and the biopsy of the site involved. So typical candidal plaques, we know that they're creamy white, they're curd-like, or sometimes the pale yellow. And from the particular site, you will be taking the biopsy of the brush, and you can stain by the periodic acid skip or the silver or the gram stain. And the microbiological structure usually depicts it as a mycelial forms with the masses of budding yeast, which are very constant of this candida infection. And the culture can be done if you are suspecting a non-albicans species. As I told you, this is very rare, but you can consider the cultures. And the radiographic studies are not primarily recommended, but they can be considered when you cannot do the endoscopy. So you can consider for the patients for the barium esophagogram, so in which it depicts the shaggy esophagus and plaques and pseudomembranes and cobblestoning if the entire esophageal mucosa has been involved. So this is how a patient of candida esophagitis usually looks. So if you see this endoscopy, the pseudomembranes, that is the plaque-like structures disseminated through the entire mucosa and which are adherent. So if you do a scraping on this, the underlying mucosa may be very hyperemic or sometimes they start bleeding. So this is also a very important thing. And if you take a biopsy of this particular site, so you can see a mycelial forms of the fungus with a budding yeast pattern. So this is a barium esophagogram of the candidal esophagitis. So you can see the discrete plaques like lesion which is oriented longitudinally along the esophagus, and the linear and irregular filling defects. You can see some filling defects here. So this is produced by a trapped barium in the distinct margins. So this is a typical feature of the esophageal candidiasis. How will you consider the treatment? The first line of treatment is usually the azoles. So they act by altering the fungal cell membrane, by altering its permeability, and by inhibiting the synthesis of ergosterol, that is the cell membrane cholesterol. So there are mainly 4 azoles which are being used in the treatment of the candida infection, that is the fluconazole, the itraconazole, the oriconazole, and the posaconazole. So although posaconazole has been preserved, the fluconazole, itraconazole are the very commonly used OPD basis treatments nowadays. If you are dealing with the azole refractory cases, then the echinocandins can be used. In this, there are 3 drugs: the caspofungin, the micafungin, and the very recently discovered the anidulafungin can be used. And if the patient is pregnant, and if the infection you are dealing is a disseminated or a drug resistance, then you can use the amphotericin B, which is a very broad spectrum and a very toxic antifungal, which we usually know of. So this is a very important thing. I think I need not go in detail with the antifungals here, because there has been already a class on the separate antifungals available in the white army pattern. In the and this is how will you treat oropharyngeal candidiasis in a patient of the HIV. And the esophageal candidiasis, the first line of treatment, if somebody asks, it is a fluconazole. And if there is an alternative, if you want, you can use an IV echinocandin or the amphotericin B. And in a refractory case, the double dose of fluconazole can be used. The usual dose which we follow is the 400 mg orally, or on day 1, followed by 200 mg 400 mg, 200 to 400 mg for 14 to 21 duration. I particularly use for 3-week duration, that is a 21 duration. If the oropharyngeal candidiasis, if you are dealing with, there are a lot of options available. You can have a clotrimazole troches, you can use a meconazole buccal tablet. These are a very common practice nowadays. They have to apply this meconazole on the buccal mucosa, which remains adherent to the buccal mucosa for some time. So this is a very good drugs available nowadays. And the fluconazole is usually a reserved therapy for moderate to severe oropharyngeal candidiasis, whereas the fluconazole is the first line of therapy for the esophageal candidiasis. This you should know. And how the herpetic esophagus differs from this, it is mainly caused by the herpes virus 1, but others like herpes virus 2, the varicella, CMV have also been associated in this. And the most commonly seen in the immunocompromised patients, but the HSV1 can occur even in the immunocompetent persons also. So how the symptoms do occur? Obviously, if there is a esophagitis, there has to be a odonophagia, and along with some constitutional symptoms, just because it is a viral fever. So you'll also have a fever, myalgia. Along with this, there is a typical odonophagia. And the bone marrow transplant recipients may have a continuous vomiting and a nausea without odonophagia as the sole manifestation of the HSV esophagitis. So this has been defined in particularly, so we need to know this. If at all a bone marrow transplant patient is coming with a recurrent nausea and vomiting, even without odonophagia, you need to suspect the herpes simplex esophagitis. And the herpes labialis, that is cold sores or on the perioral skin involvement. So these can precede or they can occur concurrently with the esophageal infection. So the diagnosis is basically by the endoscopy, and how will you confirm this? You'll confirm by the viral culture or the histological and cytological examination from the brushings, the biopsies from the ulcer edges. So this is how ulcer of the herpes simplex usually appear. So in stage 1, it is usually a small and punctured out lesion with a raised margin. So you can see the raised margin here with a slight yellowish color and fibrin exudation at the center of the lesion. So this is what is the typical early stage of herpetic esophagitis looks like. So usually located in the middle or lower third of esophagus. And this progresses to a punched out lesion without raised margins and no color and no exudation. You can see this ulcer here. So this stage progresses to the punched out lesion from a raised margin to the depressed margin. So this becomes confluent to become like a map-like structure. So you can see this, the various ulcers have become confluent by adding this. So you can remember this, the typical ulcers of the herpetic esophagus are very small with the raised edges, ultimately progressing to the depressed margins and coalescing to form a large map-like structure. And this is another herpes class virus responsible in causing the esophagitis, the CMV, which is a ubiquitous herpes virus. We know many of us may have a CMV antibodies in us. So this infects almost all the world's adults, but in healthy people, it remains as a latent infection. So the viral DNA can be detected in many tissues, including the circulating leukocytes. But this does not cause infection in a healthy adult. So this herpes cytomegalovirus, to cause an infection, the immunity has to go very, very down. So the transmission rate from a CMV seropositive donors to a CMV seronegative recipient after the blood transfusion is very common. After the organ transplantation, it is also very, very common. So it is very common practice to use the valacyclovir prophylaxis, the valganciclovir prophylaxis before doing the organ transplantation nowadays. So the CMV esophagitis can occur as a primary infection, or it can be a reactive reactivation of the existing infection occur only in immunocompromised patients. So how to differentiate between a herpes simplex esophagitis and a CMV esophagitis? Herpes simplex can cause the infection even in immunocompetent also, but whereas CMV esophagitis occurs only in immunocompromised patients. And here the infection of the virus is to the squamous epithelial cells. The virus does not cause to the lamina propria, whereas the CMV virus infects the subepithelial fibroblast and endothelial cells. So this can be the entrance question. The herpes simplex virus involves the squamous epithelial cells. It does not cross the basement membrane or the lamina propria, whereas the CMV virus involves the subepithelial fibroblast endothelial cells. Why this is important because in taking biopsy, you need to be very, very careful. So to rule out the CMV esophagitis, you need to have a deeper biopsies. Rather than herpes simplex, sometimes patient may have a co-infection with both herpes simplex and CMV, especially in a case of HIV. So if you don't treat the CMV infection, the patient might have a CMV septicemia, which is very deadly and life-threatening. So if you want to rule out a CMV esophagitis, you need to take a biopsy from a very deeper lesion. And the symptoms are very abrupt onset in case of herpes simplex, whereas in case of CMV, it is the gradual onset. And the systemic features are very, very common in case of CMV esophagitis. And how will you treat this? So this is very similar to the previous class, which we dealt with the viral encephalitis. So the acyclovir is the drug of choice for the primary treatment of herpes simplex, and the cyclovir resistant, the drug of choice is the foscarnet, and cytomegalovirus, the drug of choice is the ganciclovir, followed by you need to give a maintenance therapy till the immunosuppression resolves or till the CD4 count improves. And the secondary choice is the foscarnet, and the varicella zoster, again it is the acyclovir. So the ganciclovir or the valganciclovir are the drug of choice for the primary treatment of cytomegalovirus, whereas it is the acyclovir for the herpes simplex. If they're resistant to the primary drugs, the third drug is the foscarnet. So this is one study in which the cytomegalovirus esophagitis was detected in an immunocompetent patient also. So this can be seen in immunocompetent patient, although in this particular study, the patient did not have any HIV, patient did not have any immunosuppression secondary to diabetes or post-organ transplantation, anything. In fact, they had ruled out the idiopathic CD4 lymphocytopenia in this patient also. So this patient did not have any amount of immunosuppression, but yet was found to have a cytomegalovirus esophagitis. How will you differentiate the endoscopically the various HIV associated with esophagitis? So the Candida, we know that they are pseudomembranes, the white curdy-like structures, and herpes simplex, we know that they are punched out ulcers and presenting the small vesicles. Whereas cytomegalovirus, they usually present as a very large and shallow linear ulcerations. So this is a very, very particular thing and can be the entrance question. So herpes simplex ulcers are small, whereas cytomegalovirus ulcers are large and they are longitudinal or linear along the length of the esophagus. And the microscopic findings of the herpes simplex, we know that there are category A inclusion bodies in the epithelial cells, whereas there are cytoplasmic and intranuclear inclusions in the subepithelial fibroblast and endothelial cells, also called as owl's eyes in the cytomegaloviruses. So coming to the first question which we had taken today. So this, if you see, the patient was an HIV patient with a very low CD4 count. He was given a course of fluconazole, but did not relieve the symptoms. So the esophagoscopy done reveals this. This is a very linear, very large ulcer. So this is a very typical of the CMV esophagitis. The diagnosis here is the CMV esophagitis. So the confirmation is by the biopsy, and the treatment is the valganciclovir. If they're resistant, then the foscarnet. So coming to the next infection. So a 55-year-old female who was admitted to the hospital with acute pyelonephritis with a blood and urine culture positive for E. coli sensitive to fluoroquinolone. So she's clinically improving on levofloxacin, But on day 4 of her hospital stay, she developed the recurrence of fevers, the abdominal pain, and a new onset non-bloody watery diarrhea, the 5 episodes in 24 hours. So what is a probable diagnosis? How do you work up, and what is the management? So this is a patient who is hospitalized for some other disease developing the diarrhea. So this can be either antibiotic associated diarrhea, or this can be either Clostridium difficile infection. So this Clostridium difficile infection is a very, very important thing. A lot of the gastro field advances is being going on this particular field. If you are interested in a gastro, you need to know the CDI in detail. The lot of advantages, recent advances are being going on, especially the FMT, that is the fecal matter transplantation, is a very big thing nowadays in gastrointestinal department. So this is basically, the name came from the difficult Clostridium. This was difficult to culture earlier days. So that's why they named it as Clostridium difficile. So this is a unique colonic disease. This is a Clostridium difficile infection, is a unique disease, so which is acquired most commonly in association with the antimicrobial use and the consequent disruption of the normal colonic microbiota. So there has to be two diseases or two pre-existing conditions to acquire this CDI. There has to be a disruption of the normal colonic microbiota, and there has to be a use of an antibiotic. And this is a most commonly diagnosed diarrheal illness which is acquired in the hospital, which we should know of. So what is this Clostridium difficile? It is an obligatory anaerobe. It's a gram-positive organism, spore forming, and is widely found in nature, especially in the hospital environment. It can be found in all the hospital type of environment. It can be found on the hands of the medical staff. It can be found on the aprons. It can be found on the stethoscopes. It can be found on the surfaces. It can be found on the curtains. It can be found on the beds, floor, wall. If you take a culture from all the sites in the hospital, minimum 10 to 15 sites are going to grow this particular organism. So where this organism is been coming from, the major source is a human. So the person with the Clostridium difficile carriages are the reservoir for the environmental contamination. So many of the patients carry the Clostridium difficile organism in their intestine, although they does not have any disease by Clostridium difficile. So they act as a reservoir for the environmental contamination. And it is an organism which is highly transmissible via fecal-oral route by the ingestion of spores. So these spores are found widely in the nature. So in what kind of patients these do acquire? So very important risk factor is the antibiotic use, which we are going to deal in detail. And apart from this, the advanced age and the hospitalization. So the three very, very important risk factors are the antibiotics, the advanced age, and admission in the hospital. That is what is triple A. We know that triple R. Now we know triple A. Triple A is a very important primary risk factor for the Clostridium difficile infection. There has to be two out of three has to be there. Either patient has to have antibiotic use along with the advanced age, and admission being the risk factor. So other risk factors have also been detected, like if the patient is having a severe comorbid illness, like if the patient is admitted in the ICU for some very big surgery is being went on to the patient, especially the GI surgery, where there is a lot of alteration in the normal human microbiome. And if the patient is on enteral feeding, if the patient is on Ryan's tube feeding, if the patient is on jejunostomy feeding, this is a very particular important risk factor. And a patient of inflammatory bowel disease is also a risk factor to acquire the IBD. So this is a very common issue because many of the patients, like for example, if the patient is having ulcerative colitis, if the patient presents to you with a diarrhea, many of the times there's a tendency to think a disease is a relapse, but many of the times it has been secondary to the Clostridium difficile infection. Even I have seen the toxic megacolon in a patient of ulcerative colitis, which is secondary to CDA. So we need to have a very broad mind to deal in the patient of diarrhea of IBD. And obviously the immunosuppression in a patients of cancer and chemotherapy is a risk factor. And the gastric acid separation, that is the long usage of PPIs, have been discussed nowadays as a new risk factor for the Clostridium difficile infection. So among these two, the very important thing is the antibiotic use. We know that you should know that any antibiotic known to the humans can act as a risk factor for the Clostridium difficile infection. And among the antibiotics, the broad spectrum antibiotics are having a higher risk compared to the narrow spectrum antibiotics. The first antibiotic which was detected to be as an agent responsible for this is the clindamycin. And nowadays, the clindamycin use has been reduced a lot, except in a case of the MRSA, which has been having a proven sensitivity to the clindamycin. And among other antibiotics, the fluoroquinolones, penicillins, and the cephalosporins, being the broad spectrum antibiotics, are majorly responsible for the Clostridium difficile infection. And even metronidazole and vancomycin. Why I have mentioned this? Because these are actually the treatment of choices for the Clostridium difficile. Even the drugs which are used as a treatment for this CDI can act as a risk factor for CDI. So this is a very deadly thing to be dealt with. There are the CDI which is seen resistant to the metronidazole and vancomycin nowadays. That's why the entity of the FMT is being coming nowadays, especially in the case of recurrent CDI. So this table, which you should everybody of know of. So this can be the question: what are antibiotics which are frequently associated? You should know this particular column of the table, and which are the antibiotics which are rarely associated with the CDI. So the fluoroquinolones, the clindamycin, the penicillins, and their combinations. For example, if you have the amoxiclav, if you see some amoxicillin with sulbactam, all these are very important drugs which are associated with CDI. And the cephalosporins, especially the second, third, and fourth. The first generation cephalosporins are less commonly associated, whereas the second, third, fourth generation can be the risk factors. So this can be the entrance question. So which among this can be the lesser associated with Clostridium difficile? The option can be the generation 1, generation 2, generation 3, and generation 4. So among this, generation 1 is associated with a lesser incidence of CDI, whereas the second, third, and fourth generation of cephalosporins are associated with the higher or frequent association with the CDI. And carbapenems are also, being the broad spectrum antibiotics, are associated with this. So among the rarely associated are the aminoglycosides, and the tetracyclines, and the ticacycline, a new drug, a very good tetracycline class of drug, and the chloramphenicol, a old drug, and the drugs used for the CDI itself, that is the metronidazole and vancomycin, are usually lesser associated with the CDI. It does not mean that these antibiotics are not associated. Even the CDI secondary to these antibiotics have already been described, but these are particularly lesser incidence of association with these particular antibiotics that you should know of. So how this infection acquires in a patient. So if a Clostridium negative difficile patient gets admitted for some other disease and he is receiving some antibiotics, and if this hospital environment is having the Clostridium difficile spores, so there is a very high chance of getting infected to this patient who is particularly admitted for the antibiotics. So the infection, whatever the infection the patient has acquired, the infection can be due to the non-toxigenic Clostridium difficile. So before going to this, we need to know how the Clostridium difficile causes colitis. The Clostridium difficile basically is a toxin producing bacteria. It produces toxin A and toxin B. Very important in causing the pathogenesis of colitis. So there are some Clostridium difficile species which does not produce any toxin. So if the infection is being with a non-toxigenic Clostridium difficile, so this patient can be completely asymptomatic, but yet colonized with a non-toxigenic strain. So if the Clostridium difficile has been producing some toxins, the body does have an answer to this by producing IgG response. So if the patient is producing a toxin, but if he is having enough good immunity to mount the IgG response, then he also may remain asymptomatic to the entire period. Whereas if there is no response to this particular toxin A, then the patient becomes symptomatic. So this is a very important in knowing the pathogenesis. So patient to remain asymptomatic even after colonizing, it can be two reasons. It can be due to the non-toxigenic strain, or it can be the enough IgG response has been produced in his body. So if the patient is having a toxigenic Clostridium difficile in his intestine, and if the IgG response is inadequate in dealing with these toxins, so this patient particularly can have a colitis established in him. So how the clinical manifestations presents in these patients? They can present as an asymptomatic carriage. They can present with a diarrhea with colitis. In this, it can be a non-severe disease, it can be a severe disease, or it can be fulminant disease. So these are the very standard terminologies given by the gastroenterology associations. And it can be a recurrent disease, and there are some unusual presentations of this CDI. So the asymptomatic carriage occurs in 20% of hospitalized adults. The transmission rate is so high associated with the CDI is, for example, if the patient is admitted in one particular single ward, and if at all he is asymptomatic carriage and he is transmitted the CDI in this particular environment, and after discharging of this particular patient, the coming next patient is also exposed to the significant risk. So this is such a high transmission rate this patient particularly have. So these patients, they shed this CDI in stool, but they do not have any diarrhea or symptoms. So these individuals act as reservoirs for the environmental contamination. So the host immune response in the Clostridium difficile play a role in determining the symptomatic carriage state. So they do not warrant any screening or treatment. So we do not have any program for the community screening of all the hospital patients for the CDI, because it does not have any shown the benefit in reducing the disease. So in patients who develop disease, it can present as a non-severe disease where the predominant symptom is the watery diarrhea. So many of the students might think it is a colitis, though there may be a mucus or blood, so it is usually dysentery. No, it is usually diarrhea, that is a watery diarrhea. The mucus or blood in the stool may or may not be associated. There can be an associated symptoms of the lower abdominal pain, the cramps, some low-grade fevers, the nausea, anorexia are very, very common in these patients. And in non-severe disease, the total leukocyte count is usually less than 15,000, then there is a normal creatinine. And the unexplained leukocytosis should increase the suspicion. So any patient who is admitted for some comorbidity or other diseases, he's been receiving some antibiotics which are known to cause CDI. After some duration, if the leukocyte count is not coming down, or if it is rising rather than the reducing, you need to suspect this colitis in these particular patients. And sometimes the symptoms occur within 2 weeks of antibiotic therapy. For example, if the patient has received antibiotic for 7 days and now he is discharged. So after discharging, after completion of the antibiotic therapy, for the next 2 weeks, he can have the risk of having the CDI. So this is a very, very important thing which everybody should remember. It need not happen during the course of running antibiotics. It can happen after 2 weeks, the stopping of antibiotic therapy also. And sometimes the disease can become severe with the leukocyte count going above 15,000 and creatinine increasing, having an acute kidney injury. The patient can have very high grade of fever, abdominal distension. Patient can have dehydration secondary to the recurrent diarrhea and may have a lactic acidosis. And hypoalbuminemia can also be there with the peripheral eosinopenia. So any patient who is improving from the antibiotics now having diarrhea presented with the leukocytosis with eosinopenia and the low albumin, you need to suspect the severe CDI. The management differs here. That's why the severe and non-severe classification is very, very important. We know in enteric fever, there is eosinophilia, whereas in CDI, there is an eosinopenia. So you need to remember this trick in diagnosing the patients. So the fulminant patients can have severe hypotension, which is refractory, can become shock, leading to multi-organ dysfunction. Or sometimes patient can have ileus, patient can have bowel perforation or peritonitis, or the patient can develop megacolon. So megacolon definition, everybody of us know it is more than 7 centimeter of the large colon or more than 12 centimeter of cecum. It's a criteria to diagnose the megacolon. So recurrent disease, the recurrent CDI is defined as the resolution of symptoms while on therapy, followed by reappearance of symptoms within 2 to 8 weeks after treatment has been stopped. So sometimes a single recurrence can progress into the multiple recurrence. So this particular recurrence is very, very common in patient who is aged more than 65, who is having a severe comorbidity. And if there is a lack of response to the toxin B of the CD, the recurrence is very, very common. And this recurrence is usually more commonly due to relapse rather than reinfection. There may be some spores which are remaining inside the intestinal mucosa rather than a new reinfection occurring in these patients. And there are some unusual presentations like protein losing enteropathy leading to chronic malabsorption have been available in the literature, and some extracolonic involvement, like it can be the reason for appendicitis. It can cause the small bowel involvement very rarely. The soft tissue infection like the Clostridium perfringens have been detected in Clostridium difficile, and bacteremia into sepsis and reactive arthritis. This can be the one of the organism leading to the reactive arthritis along with the other organisms like ureaplasma, the Campylobacter. It can be a reason for the reactive arthritis. So how will you diagnose this patient? So the diagnostic approach is basically being implicated in a patient who is having acute diarrhea. That means more than 3 loose stools for the 24 hours with no obvious alternative explanation, and with relevant risk factors like if the patient has received antibiotic, it is advanced age, and the hospital admission, these need to be evaluated for the Clostridium difficile infection. So how will you evaluate this patient? So you can do the testing of this liquid stool. Remember, the liquid stool is the sample for the diagnosis. This is a very, very important. You cannot send a hard stool for the CDI. So only a patient of diarrhea who is having a loose stool can be tested for a CDI. The hard stool is not the adequate sample or ideal sample to test for CDI. So you can test this liquid stool for the gene, or you can directly test for the enzymes like the GDH or the glutamate dehydrogenase, or you can test the toxins in the stool. Then there are some tests like you can do the culture, and you can use the cytotoxicity assays also. So what are the ideal tests available? We'll discuss that. So you can test the genes available, you can test the toxins, you can test some enzymes produced by this particular CD. So just because some toxin is detected in the stool cannot directly implicate as a causative organism for colitis. That is why the hard stool cannot be sent for the analysis. It has to be analyzed in the liquid sample also only. So what is there is a 2-scale investigation which is being practiced in the day-to-day practice. So in a diarrhea stool specimens, the Bristol stool scale above 5 is the only criteria to be sent for the CDI. If you are sending Bristol 1, 2, 3, 4, they will not test it for the CDI. They will directly, the microbiology department directly refuses the sample. Excuse me for 1 second. Hello? Hello? Same treatment happens. So instead of directly testing for the NAT, because the nucleic acid amplification test is a very costly test and which has a very high specificity, we need to use a test which is been a very sensitive in earlier. So first we will test for the glutamate dehydrogenase enzyme and a toxin assay by the enzyme immunoassay, because these are easily available in all the laboratories and they are less costly compared to the nucleic acid amplification test. So if both the tests are positive, then you can directly consider for the CDI without going for the NAT. Hello. Okay, I'm not looking for distractor. ನಾನು ಸ್ವಲ್ಪ ಕ್ಲಾಸ್ನಾಗ ಇದೀನಿ ಮೆಸೇಜ್ ಮಾಡಿ ನಾನು ಇದು ಮಾಡ್ತೀನಿ. ಓಕೆ. Amyloid code is symptomatic code is code. If both are negative, then the CDI is very unlikely in this patient. If there is an equivocal report, like if one has come positive and one has come negative, then to confirm, we can go ahead with the nucleic acid amplification test, which usually confirms the diagnosis. If it is positive, then along with the clinical assessment, you can consider the CDI. If it is negative, the CDI is very, very unlikely. So the first test which has been advised in the patient to rule out the CDI is the enzyme immunoassay to diagnose either the glutamate dehydrogenase or the toxins available. If the both are positive, then it is positive. If both are negative, it is negative. If there is an equivocal report, then you need to test the sample for the nucleic acid amplification test. The other two tests are very rarely conducted in routine practice because they're time consuming and they require the expertise and the laboratory availability. And there are some adjunctive diagnostic tools available like the radiographic imaging. Sometimes you need to be considered, especially if you're suspecting some ileus, if you're suspecting some megacolon, if you're suspecting severe disease, you can consider the patient for the CT abdomen, or if the patient, you're considering for the alternative diagnosis. So, or if the patient does not have any diarrhea, like ileus, if the patient have the colitis and it has led to ileus, the patient may not have any diarrhea, then you can consider the endoscopy and some rectal swabs can be taken for the diagnosis. So how will you treat the patient of CDI? So in a patient of non-severe disease and severe disease, there are three drugs available. The one is the fidaxomicin, then the vancomycin, and the metronidazole. Remember, all the things given are orally. They are not given IV. The vancomycin is given orally only for Clostridium difficile infection. So the fidaxomicin is not available in India, which should not. So in India, we usually either give a metronidazole, which is very easily available, or we go for a vancomycin, whereas vancomycin usually is a better first choice than the metronidazole. So the doses I have given here, the duration is usually 10 days or sometimes 14 days if you are using metronidazole. So metronidazole you use only for non-severe disease. The metronidazole is not being used in a severe disease. Remember this particular. In severe disease, we use either vancomycin or fidaxomicin. So since fidaxomicin is not available, so we will be using the vancomycin. Severe disease means the TLC is more than 15,000, the creatinine is more than 1.5. And in the fulminant disease, if the patient does not have any ileus, then you can go for either vancomycin or metronidazole. The fidaxomicin is not used for a fulminant disease. This is a lot of questions can be set up based on this particular chart. So if the ileus is present, so you cannot give anything orally. That is very, very important. So you can consider the additional things like the fecal matter transplantation can be done, which is administered rectally, or you can consider the rectal vancomycin. You can give it as a retention enema of 500 mg in 100 ml every 6 hourly. So this is a very, very important thing. If the ileus is present, there is no scope for either vancomycin or metronidazole given orally. The only alternative choice is the rectal administration. You can consider the rectally administered fecal matter transplantation or the rectally administered vancomycin for the fulminant disease in presence of ileus. How will you treat the recurrence? So the first recurrence, the drug of choice is either fidaxomicin or the vancomycin is a tapered regimen. Or the adjunctive treatment can also be considered along with these two, that is the bezuclastinib. So this is the newer drug approved for the Clostridium difficile infection, the monoclonal antibody. You need to remember this particular drug. This is a potential entrance question. The bezuclastinib is a newer drug approved for the Clostridium difficile infection. So where it is approved for the recurrence only. It is not approved as a primary treatment. So it is approved for the recurrence treatment, and it is approved only as an adjunctive treatment. It is not used as a single agent. So the three entrance question can be there based on the bezuclastinib. So the newer drug, the name itself can be the entrance question. So the indication can be the entrance question. It is used as a recurrence the first or the second or a multiple recurrence, it can be used, or it can be considered as an adjunctive treatment only. It is not used as a single agent. So nowadays there has been a recent advances that the FMT can be considered in a patient of first recurrence, although for nowadays the FMT is considered only if in a presence of the second or a multiple recurrences only. And the scope for rifaximin is present only in the second or multiple recurrences only. So the entire table, it is very difficult to just read out. So you can go ahead with the doses and all, the duration and all. So I will be mentioning the important things which we should focus here. So how the entrance questions can be set. So the first, the drugs which can be used in the non-severe disease, drugs can be used in severe disease, the drugs name itself they can use. So what is the drugs which are used if the ileus is present, and what is a newer drug approved for the recurrent CDI infection, that is a bezotoxumab, used as a treatment for recurrence only and only as an adjunctive treatment only. And the scope for rifaximin is being there only in the multiple recurrence stage. Otherwise, rifaximin is not been advocated as a primary treatment in a first occurrence or a first recurrence or a primary treatment. It is available only for a second or a multiple recurrence, and that too along with the vancomycin in the background. So this is a very, very important thing. And what are the indications for FMT? FMT is considered only when there is a recurrence, or if there is a primary treatment in the presence of ileus, that too administered rectally. You need to remember these very, very important things in managing the CDI. CDI is a very, very important thing nowadays. So we know that any antibiotic we usually practice in day-to-day life can present with a diarrhea that is called as an antibiotic associated diarrhea. That is AAD, very standard terminology. So this AAD, how it differs from the particular Clostridium difficile infection. So you need to know some characteristic differences between a normal, the AAD and the AAD caused by the Clostridium difficile infection. So one very important thing I tell you to remember here is, it is a colitis. Clostridium difficile causes colitis. Whereas the antibiotic associated diarrhea, it is usually due to alteration in the normal human microbial flora. There is no epithelial invasion, there is no loss of the epithelium here, there is no loss of the basal membrane. It is just the alteration in the normal human microbiome is responsible for the normal antibiotic associated diarrhea. Whereas in Clostridium difficile infection, there is colitis. So keeping in this background, if you know the differences here, the diarrhea here, it can be florid. There is an evidence of colitis, the cramps, the pupil leukocytes are very, very common as there is an inflammation. Whereas in case of normal AAD, the symptoms are usually moderate. It is called nuisance diarrhea without evidence of any colitis. So there are no fecal leukocytes appearance. And if you get a CT or a colonoscopy, the colitis is very, very common. The pseudomembranes can be present. Whereas in case of normal antibiotic associated diarrhea, the endoscopy or colonoscopy is usually normal. And the complications are very common in case of CDI, whereas apart from the fluid depletion, if it is not dealt properly, the only complication. The laboratory can positive and negative. This is a very important thing. And the treatment, it is just a normal condition which usually resolves on its own after the stopping of antibiotics or need some probiotics. Whereas in case of CDI, the patients usually progresses without treatment. So very, very important is the antiperistaltic agents like the loperamide, the resveratrol, all these drugs cannot be used in this particular CDI infection, where they can be used simple antibiotic associated diarrhea. And the oral metronidazole or vancomycin are not indicated in case of normal antibiotic diarrhea, whereas they have been shown the prompt response in CDI. And in short, we discussed some important things about the Whipple's disease. Whipple's is first discovered by the scientist called the Dr. George H. Whipple. And the causative organism was the Trapherima whippeli, a very lazy organism, a very, very rare disease in the entire world. I have not seen a single patient of Whipple's in practice. So it is very difficult to diagnose also, and you need to have a very high suspicion to diagnose. So this particular scientist described the patients who presented with the gradual loss of weight and strength, a stool consisting of the neutral fats and fatty acids, and some indefinite abdominal signs with a peculiar multiple arthritis. So these patients ultimately died due to improper treatment. So this particular disease, the scientist described as an intestinal lipodystrophy due to presence of an lipids inside the cells. So later on, the condition was found out to be caused by this particular organism, that is a bacteria called Tropherema whippeli, and later named as a Whipple's disease as a response. So this organism is a gram positive, the non-acid fast, and the PAS positive bacillus, that is a periodic acid skiff positive bacillus. It is a very extremely slow growing bacteria. So if you ask me which are the very extremely slow growing bacteria you know of, one is this Tropherema whippeli and the Helicobacter pylori. So these are extremely slow growing, so it is very difficult to culture them. So initially, when they used a culture method to isolate this organism, the doubling time was 18 days. Although with the newer cultural techniques, it has been shortened to 4 to 5 days. It is still very high compared to the routine discovered bacteria. Like they usually doubling time is within seconds or hours, whereas the doubling time of this particular bacteria is 4 to 5 days in a recent cultures. Earlier, it is 18 days in old cultures. So this is a ubiquitous environment. So whatever the organisms we discussed today are all ubiquitous. They are present in all the things. So mainly they are detected in sewage, and they are more prevalent in the fecal samples of the sewage workers. So what happens in this particular virus if it enters the body? So the major route of transmission is the fecal-oral route. So for example, if there is an entire GI tract, so this antibiotic invades or uptake is being done by the various sites. It can be uptaken by the sinuses mucosa, it can be uptaken by the respiratory epithelium, it can be uptaken by the synovial epithelium, it can be uptaken by the GI cells, it can be uptaken by the brain cells. All the cells, whatever the exposure is being coming, they are able to invade or uptake this particular bacteria. And after uptaking of this organism, there is a remarkable lack of inflammatory response in eliminating this organism. For example, if there is an uptake, so of the organism by the macrophages, the reduced intracellular degradation of this Whippeli, causing to decreased activation in the co-stimulatory pathway. We know that any organism which comes into the body usually taken by the antigen presenting cells which digest this bacteria and they present it to the T cells, which ultimately does the proliferation and fights with this bacteria. So this entire mechanism is being remarkably lacking in particular Whipple's disease. So the reason for this is particularly not known. How does this organism does this all the immunosuppression or the local immunity? It is not been detected. But this particular disease has also been described as a macrophage associated disease. There has been a controversy regarding this to describe Whipple's disease as a macrophage associated disease, but it has not been proven now. But there is definitely a lack of normal inflammatory response to this particular bacteria. So how does this usually presents? So the spectrum of disease is very wide. It can have a multi-system disease. There is no single particular point towards which it predicts the presence of the Whipple's disease, and it is usually present over time. Like it is usually the patients have symptoms for years together to get diagnosed as a Whipple's disease. So, and there has been a reports like the disease being unmasked or the accelerated by the immunosuppressive therapy, especially the cancer chemotherapy, but it can unmask even the immunocompetent patients also. So it usually affects the Caucasians, elderly, and the farmers. We know that it is a very frequent contaminant of the sewage and sewage workers. So the elderly farmers are particularly exposed to this, and it is a multi-system disease, and the spectrum is very wide, and it is a chronic disease. So what is a classic Whipple's disease that has been described? It is described for the 4 cardinal clinical manifestations. That is the arthralgia, that is a joint symptom. and GI symptoms, that is the weight loss, the diarrhea, and the abdominal pain. So these are the classic very four cardinal features. The one is joint symptom along with GI symptom. The joint symptom is arthralgia. The GI symptom is there is usually diarrhea with pain abdomen along with the weight loss. So how does the joint symptom present? So this is a very common symptoms. This present in 80% of patients, and it typically presents as a migratory arthralgia of large joints. So we know that the migratory polyarthritis is a feature of an acute rheumatic fever. So in acute rheumatic fever, it is a acute migratory polyarthritis or arthralgia, whereas in Whipple's, it is a chronic migratory arthralgia of the large joints. But it is not a must rule to have a migratory arthralgia because there is no clear characteristic pattern associated with this. They can present as a persistent arthritis, they can present as a monoarthritis, they can present as a chronic oligoarthritis also. But the joint destruction or the deformity is very rare, so you cannot see a deformity, you cannot have some abnormalities in the joints. The joint erosion on the x-rays are very, very rare in case of this particular disease. And the peripheral joints are very commonly involved, especially the knee, elbow, shoulder, the wrist are very, very commonly involved. And many of the patients might have initially received the immunosuppressive therapy as misdiagnosed as the seronegative, the rheumatoid arthritis, or undifferentiated inflammatory polyarthritis, which is usually the common diagnosis we usually keep in the patient of the chronic polyarthritis with a negative RA or anti-CCP. So we label them as seronegative RA or we label them as undifferentiated RA. So many of these patients of Whipple's have received treatment of rheumatoid arthritis for years together without any response. So ultimately getting diagnosed as a Whipple's. So after the joint symptoms of some years, these patients develop some GI symptoms, occur late in the course after the initial joint symptoms. The most common presentation is usually intermittent diarrhea with the colicky abdominal pain. The diarrhea can be watery. There can be a steatorrhea present. Sometimes the gross GI bleeding can be there. So the presentation can be various. And these patients can ultimately progress to have a severe wasting syndrome and weight loss secondary to the chronic malabsorption or protein losing enteropathy. And later they may find the abdominal distension due to the ascites, to the chronic malabsorption. So in these particular kind of patients, it's very difficult to have a suspicion regarding the Whipple's disease. You may be thinking of some protein losing enteropathies, you may be thinking of some chronic liver disease or other diseases, whereas it is a Whipple's disease in background which is running the patient. So you need to suspect a patient of a chronic joint symptoms now presenting as a predominant GI symptoms in the huge weight loss and a wasting syndrome. There are some additional features like the systemic features can be present, like the fever can be present, and lymphadenopathy, like mesenteric lymphadenopathy, the aortic lymph nodes are enlarged. So this is very, very common. So many of the patient presents with the diarrhea, chronic diarrhea, joint symptoms. You may get CT. So you may see something describing as a mesenteric lymphadenopathy, although without any necrosis. They are reactive lymph nodes. The neurological manifestations, which you can discuss later in detail, the very commonly it is associated with the dementia, some supranuclear ophthalmopathy, the nystagmus, the myoclonus are very, very common. The cardiac manifestations are also very common. The predominantly it is endocarditis, although very rarely the pericarditis and myocarditis is very, very common. So culture negative endocarditis, you need to suspect the Whipple's disease. Then the pulmonary features like the pleural effusions, the chronic cough, the ILD-like picture is common. The pulmonary hypertension is common. Like if you see the actually SLE and the Whipple's, is very, very similar disease. Just a Whipple's disease is a infection, so you need to give it antibiotic. The SLE is a autoinflammatory condition, so you need to give immunosuppression. So many of the times the patient might be receiving a wrong treatment in the background of a wrong diagnosis. So the suspicion should be very high to diagnose Whipple's disease. Only if you know this particular disease, you can suspect the patient. So any patient who has been running a huge course for the entire years, undiagnosed, not relieving symptoms after the wrong diagnosis, the Whipple's disease test should be done. The dermatological manifestations of skin hyperpigmentation can also be seen. The laboratory things, the chronic inflammation manifesting as anemia, the high CRP, ESR, the albumin is very low, elevated PT due to vitamin K malabsorption. So all these are very, very common in these patients. The CNS is a one particular discussion which we should take off here. The classic repulse, it can occur, or it can occur as a manifestation of relapse also. So the isolated CNS infection is very rare, although in many patients who are asymptomatic of the CNS pattern, if you get the PCR by CSF, it may be positive, but they can be asymptomatic. So in symptomatic patient, the majority of the presentation is a dementia or the memory impairment or some cognitive impairment with the confusion. The cerebral ataxia is also very, very common. One of the cause for GI involvement with the cerebral ataxia is the Whipple's disease also. There are other associations which you should know of. This is a question for you guys, so you need to come with the answer. The GI symptoms with the cerebral ataxia, what are the diagnoses? There are some neurological pathognomonic signs of this Whipple's disease. The one is the oculomasticatory myorrhythmia or the oculofacioskeletal myorrhythmia. It is basically the skull structures going into myorrhythmia or myoclonus. So if you Google or if you go to the YouTube, you can see the videos of this oculomasticatory myorrhythmia going on in the patient of Whipple's. So this can be the pathognomonic features. Although these are very rare features, these are but pathognomonic. If you see this patient, you need to suspect the patient for Whipple's. The endocarditis is per se very rare. It is described only in small number of patients. And in this particular endocarditis, patient may not have the classical clinical feature. They may just present as a pyrexia of unknown origin or some other disease rather than the typical endocarditis we know of. So in most cases, the diagnosis is usually made after the valve has been resected for the management purpose. So if you, the post-resection, if you send the patient for the analysis, the patient may have a significant fibrosis and slight inflammation, and the culture was negative. So you need to suspect Whipple's. So any patient who is culture negative, who has undergone valve resection, if you do the valve pathology analysis, there is a significant fibrosis, but there is slight inflammation. You need to suspect three particular diseases here. One is the Whipple's disease. Another one is Q fever. Another one is Bartonellosis. This can be the entrance question. The very common organisms associated with the culture negative endocarditis and post-valve resection, there is very slight inflammation or very less number of inflammatory cells on this, but there is a significant fibrosis. So you need to suspect very three important organisms, that is the Whipple's disease, the Q fever, and the Bartonellosis. So this is a diagnostic algorithm to be practiced to diagnose the Whipple's disease. Is a very difficult thing to diagnose. So before diagnosing this difficult thing, you need to rule out a very common thing associated with this particular discussion, that is IBD. So IBD, that is inflammatory bowel disease, can have the joint symptoms along with the GI symptoms. Then the infectious diarrhea. There are some infectious diarrhea can presenting as a reactive arthritis, as a joint involvement along with the diarrhea. So you need to rule out the correct tissue disease. As I told you, you need to rule out disseminated tuberculosis. You need to rule out the hyperthyroidism. So you need to rule out the advanced HIV infection. Only after ruling out the common diseases, you need to consider the diagnosis of this. So the first is the sampling. Where to take the sampling here? The sampling is usually the gastroscopy or duodenoscopy with multiple small biopsies taken, like more than 5 biopsies. I think there is ideally 7 to 14 biopsy samples are taken from the various areas. So first thing you do is the pass staining of this sample. If the pass positivity is seen, like pass positive macrophages which are infiltrated with this bacteria, then the PCR with this PCR is being done on the particular sample along with the immunohistochemistry. Along with the immunohistochemistry or the PCR, if either of this is positive, then the Whipple's disease is confirmed. And if the past positive macrophages were there, but if PCR and immunocompetent immunohistochemistry is negative, then the tentative diagnosis is considered, and you can consider as a tentative diagnosis. Then is for tentative diagnosis, you can consider the alternative sample from the other areas. You can get a CSF sample, you can get the brain biopsy, you can get the synovial sample, you can get the synovial biopsy, you can get the bone marrow, you can get the heart valve, you can get the lymph nodes. So for the tentative diagnosis, you need to consider this. So to go through this particular very important and very tedious chart. I will tell you the simple chart. First, get the biopsy and the past staining, the one test. Next is the PCR test. Next is the immunohistochemistry. So among this, if two are present, then it is the Whipple's disease which is confirmed. If only one is present, then it is a tentative diagnosis. So in any tentative diagnosis, you need to get the alternative sample also. In alternative sample also, you apply these two tests. You apply PCR, you apply the past staining, you apply the immunohistochemistry. And among this, any two are positive, then it is a Whipple's disease. And if only one is positive in that particular additional tissue, then it is a tentative diagnosis. Then it is an individualized decision to consider for the treatment or not. The treatment, I will not go in detail, but remember the duration here. The first treatment is usually 2 to 4 weeks. It is either the penicillin G, which is used as a 2 million units IV for 4 hourly. It can consider for 4 million units in case of CNS infection, or it can be considered for the endocarditis. And it is 2 weeks for all the GI infection, whereas it is 4 weeks for the endocarditis. So it is 2 to 4 weeks induction regimen you can consider. We are using either ceftriaxone or a penicillin G. After this 2 to 4 weeks induction therapy, we practice a maintenance therapy for 1 year. So in this particular maintenance therapy, there are two regimens available. You can use either Ceptran, that is the trimethoprim sulfomethazole double strength dose, or you can use a combination of the doxycycline with the hydroxychloroquine for 1 year. So the patient need to receive an antibiotic for 1 year. There's such a huge duration they need to receive. So the compliance is very low in this particular regimen. That's why the relapse is also very high. Even if the patient takes for 11 months and leaves for last 1 month, the relapse chance is very high. So the last discussion for today is the Helicobacter pylori infection. So this is again a another very important organism which everybody of you should know, especially the lot of advances are going on the gastro field in this particular infection. So H. pylori is a spiral shaped organism. The shape is very important to remember. It is microaerophilic, even it can survive with the low oxygen tensions. The gram-negative bacterium is measuring the approximately 3.5 microns in length and 0.5 microns in width. And it is a very slow-growing organism that can be cultured on blood agar, or there is selective media or the spirose medium. This can be the question again. So the biochemical characteristic is very important. It is all positive. That is, it is catalase positive, it is oxidase positive, well, it is urease positive. So very important is the urease positive here. Why this is important? H. pylori. H. pylori is a don. I call it as a don because any bacteria which comes in the gastric acidity is going to die, whereas this particular bacteria is going to survive in the gastric acidity. That's why it is a don bacteria. So how this survives in this particular gastric acidity? So you might have studied in the pathology in this particular thing. So the two things which protects it from the gastric acidity is the urease and its motility. So once it enters the gastric mucosa, through the urease, it converts the urea into ammonia. So this ammonia acts as a base. So this tends to neutralize the environment surrounding this bacteria, reducing the acidity. So along with this, the flagella and the spiral structure of this is very important in its motility. So it tries to move through the mucosa involving the epithelium cells. So the mucus penetration is by the two mechanisms. One is the urease production, another one is the flagella. So now it tends to adhere to the epithelium by some adhesins and toxins. So if you see this H. pylori infection, it is the most common chronic bacterial infection in humans. It is seen in worldwide, it is seen in all individuals of all ages. So it is estimated that 50% of the world's population is being infected with this H. pylori. So If two are there, two among one, if you see, is already having H. pylori in his stomach. So this is even higher in case of underdeveloped countries. So in this underdeveloped countries like India or developing countries, the majority of the children are infected before the age of 10 only. By the time they come to adolescence, all the children have been infected. And the prevalence in adults is peaks more than 80% before the age of 50. Whereas in developed countries, the evidence of infection in children is very, very unusual, but it becomes more common during the adulthood. And how does this bacteria particularly transmit from one person to another is incompletely understood, but it is being predicted that the humans are the major reservoir, and the feco-oral or the oro-oral transmission appear to be most likely, especially among the children of similar ages. So we know that what this pathology H. pylori causes. So it causes the acute or the chronic gastritis. It causes the gastric atrophy. It causes the duodenal ulcer. It causes the gastric ulcer, and it causes two malignancies. One is the gastric cancer. Another one is the mucosal lymphoma of the gastric mucosa, that is malt lymphoma. So there has been a predilection to the particular sites of this H. pylori presentation. So H. pylori is usually causes an antral predominant gastritis. So what happens in the antral predominant gastritis is it destroys the cells which produce the somatostatin. We know that somatostatin inhibits the gastrin release. So since the H. pylori destroys the somatostatin producing cells, and somatostatin has a negative feedback on the gastrin, the H. pylori infection, by destroying the somatostatin cells, increases the gastrin release. So this increased gastrin release increases the acid secretion in the antral part of the stomach. So the acid secretion is intact. In terms, the acid secretion is increased in this particular site, that is the antrum of the stomach. So the ulceration is very, very common in the antral predominant gastritis. So this is very, very important. Whereas the corpus predominant gastritis, the body of the stomach, in this, the somatostatin producing cells have very, very less. Here, it usually causes the atrophic gastritis. So here, it causes the atrophic gastritis, and also it causes the hypochlorhydria due to destruction of the acid producing cells. So it is usually atrophic gastritis in a corpus predominant or pan-gastritis. Whereas in case of antral predominant gastritis, it is usually an ulcerative gastritis. So this particular site predominance of the H. pylori you should know of. So in a patient of antral predominant gastritis, they usually present as a duodenal ulcer or a non-ulcer dyspepsia, which is also called as functional dyspepsia. Whereas in a corpus predominant gastritis, the acid secretion is usually reduced. So it causes the atrophic gastritis, which is a very important risk factor for the CA stomach. So this is a picture showing natural history of the H. pylori in one slide. So 50% of the world population has been infected. So after infection, all the patients who are infected have a microbiological gastritis. So all the patient who has been infected with the HIV can usually have a chronic gastritis. What is chronic gastritis? Gastritis that does not mean patient coming to you and telling gastritis. Gastritis is a microbiological diagnosis. Here there is an inflammatory infiltrates in the mucosa. That is what defines gastritis. The symptoms of epigastric discomfort, resto-sternal burning, as the patient use this terminology as a common layman language of gastritis. It is not gastritis. The gastritis is only a microbiological diagnosis. Excuse me. Hello? Hello. ಇಲ್ಲ ಅದು ಆಪ್ಥಲ್ಮಾಲಜಿಸ್ಟ್ ಕಳಿಸ್ರಿ ಗೌರ್ಮೆಂಟ್ ಹಾಸ್ಪಿಟಲ್. So after having acute infection in a very rare patient, which may present with the symptoms of dyspepsia as an acute setting, the majority of the patient or all of the patient are progressed to have a chronic gastritis. So in this chronic gastritis, the majority of the patient usually present with a non-atrophic pan-gastritis. So this particular non-atrophic pan-gastritis can either progress to the asymptomatic infection or sometimes it can progress to the lymphoma. In some patients, it presents to the antral predominant gastritis, which can have a duodenal ulcer. So in some patients, it can have a corpus predominant atrophic gastritis or a multifocal atrophic gastritis. In very rare patients, it can present as a gastric ulcer. In the majority of the patient, it progresses into metaplasia or sometimes dysplasia and progresses into the gastric cancer. This is what is the pathogenesis of the H. pylori induced CS stomach. So, does all the patient exposed to the H. pylori behaves in a similar way? No, it is different. It depends on the patient's response and host response. If the patient's response is a hyperacidity, then they usually present with ulceration. If the patient's response is an antigenic stimulation, so usually present as a B-cell lymphoma, as a maltoma. If the patient's response is the atrophic gastritis, they can be exposed to the risk factor of non-cardiac gastric adenocarcinoma. So the odds ratio is being described for all the things here is more than 1. That means there is a significant risk factor associated with the CS stomach duodenal ulceration as a positive agent. Whereas if you see this, the H. pyloris in causing reflex esophagitis and sequelae, the odds ratio is less than 1. That means it is protective. Some studies have shown the protective effect of the H. pylori in the reflex esophagitis and the Barrett's esophagus and the esophageal adenocarcinoma for that matter. Why this is seen? Because as I told you, the corpus predominant H. pylori infection is atrophic one. So it actually causes hypochlorhydria. So this hypochlorhydria usually reduces the reflux. Since the gastric acidity itself is low, the occurrence of Barrett's esophagus is also very, very low. So the H. pylori has been detected as a protective factor in GERD and the Barrett's esophagus and so on, that is the esophageal adenocarcinoma. Whereas it is a causative agent for the adenocarcinoma of the stomach. There are some other non-gastric associations of also. The majority of them are the iron deficiency anemia and the primary thrombocytopenia. So there are 3 organisms associated with ITP. One is HIV, another one is hepatitis C, another one is Helicobacter pylori. So we usually consider for the undiagnosed primary ITP patients, apart from ruling out HIV and HCV, we usually consider for them endoscopy to rule out H. pylori infection. Many of the times, eradication of H. pylori have treated the ITP in the background. Similarly, the iron deficiency. So any patient who is having unexplained iron deficiency and unexplained ITP should be tested for the Helicobacter pylori for the strong association, and this can be the entrance questions also. There are other associations also, and in fact, it is been growing in the list. The moderate association has been seen with the vitamin B12 deficiency anemia, the central serous chorioretinopathy, the psoriasis, and some neurological diseases. And there are other weak associations like the rosacea, acne rosacea, the open-angle glaucoma, the chronic urticaria, the alopecia areata, and others like the inflammatory bowel disease, the esophageal diseases, the allergic diseases. So these are very, very important thing. The one which we should remember is the iron deficiency anemia, the primary ITP, the vitamin B12 deficiency, and rosacea have been asked as an entrance question already. So what are the indications for the H. pylori testing? So as I told you, all the 50% of the population of the world is being infected. So do you consider for the community screening? No. Why? Because the eradication of H. pylori does not shown in reducing the occurrence of the CS stomach in worldwide. That's why the community screening is not being advised for the H. pylori testing. There are some indications in be given for the H. pylori testing. One is the active PUD, any patient of the PUD. So if you do an endoscopy and if you see the ulcer, either in the gastric mucosa or a duodenal ulcer, you need to test for the H. pylori. It is a must. Then there is a history of PUD, but there is no treatment of the H. pylori is being received to the patient. Then you need to consider for the H. pylori testing. And the low-grade gastric maltoma you need to consider. And if the patient has been underwent the endoscopic resection of the early gastric cancer, or if the patient is having uninvestigated dyspepsia, if the population prevalence is 20%, it is much more in India. So any patient who is having uninvestigated dyspepsia. So if you see this last indication, actually, if you sit in an OPD, every alternate patient coming to you with the dyspepsia, so you cannot consider H. pylori in all the patients. So if the patient having some warning signs, if the patient's age is very high, if the patient is having the risk factor for other risk factors for the CS stomach also, so you need to consider the testing for the H. pylori in these particular patients. So what are the tests to diagnose this patient? So there are some non-invasive tests and some invasive tests. Invasive is basically endoscopy. So after doing endoscopy, you can do the histology of the particular ulcer or the mucosa, or you can test the rapid urease test on that particular sample of the biopsy, or you can culture the organism. So the histology is very, very important. The excellent sensitivity and specificity. In particular, my practice, I usually follow this particular histology along with the silver staining for an ideal ultimate diagnosis. It is expensive, but it carries a very high sensitivity. Especially in the patient having ulcer and has not received a treatment of H. pylori. In my hospital also, there is guidelines for using this histology only rather than rapid urease test. The rapid urease we usually practice only as a matter of follow-up rather than taking multiple biopsies or the multiple cost issues in reducing this patient. So the rapid urease can be done and the culture can be done. The culture is being done only when there is an antibiotic resistance is been the question. There are some non-invasive tests. The non-invasive tests are usually given for usually followed in the community screening or in a patient who is being after receiving the treatment to know the remission. The non-invasive tests are done. In my particular hospital, we usually use the stool antigen test, which is having a high positive predictive value and negative predictive values after the treatment, especially. So although it is a nuisance, but it is a very good test. The other test you can be done is a urea breath test, and you can use a serology. The serology is widely available, not inexpensive also, but not a good test with a very low sensitivity and low specificity in diagnosing these patients. So in my practice, we use the histology, very rarely the rapid urease test, and the stool antigen test for the monitoring of these patients. So how will you treat this patient? The treatment is very, very important here. What is the basic treatment? The duration is important. It is 14 days. Although the 7 days regimen and 10 days regimen have come, but it is better to use the 14 days regimen. And what is the basic combination? It is the 2 antibiotics and 1 proton pump inhibitor is the drug of choice. So you need to use this in combination in reducing or eradicating the H. pylori. This is a very, very important thing. So what is the most common regimen used worldwide? Is the OCA regimen, that is the omeprazole, the clarithromycin, and metronidazole. And this is the only FDA approved regimen for the H. pylori. So this is very, very important. But what the guidelines tells is, don't use clarithromycin-based regimens if the community prevalence of clarithromycin resistance is more than 15%. So the guidelines, all the guidelines, the Maastricht guidelines, the American Gastroenterology Association guidelines tells you that don't use clarithromycin-based regimen if the community prevalence of clarithromycin resistance is more than 15%. So next question is, what is the community prevalence of clarithromycin resistance in India? In India, it is more than 65%. So next question is, why are we using still a clarithromycin-based regimen? I have seen lot of patients receiving the OCA regimen in India, even without testing for H. pylori only. The patients usually blindly receive this HP kit in their treatment which usually contain clarithromycin. So it is not a good thing to use clarithromycin-based regimen in India. So there are other regimens also, that is OCA regimen. Here the metronidazole is replaced by the amoxicillin regimen. Nowadays, the first line treatment is being considered with the 4-line drugs. Here, it is the bismuth containing regimen, also called as OBTM regimen. Here they are using the omeprazole, the bismuth subsalicylate, the tetracycline, and the metronidazole. This is a very good regimen. This is presently the regimen which I am using for the first line therapy, and this is, I think, been advised for the AGA also to use the 4 drugs regimen as the initial therapy rather than the clarithromycin regimen. If you are very sure that your patients are responding to clarithromycin, if your community prevalence is very low, then you can go ahead with clarithromycin based regimen. It is pretty good. But if the resistance pattern is very low, you cannot give the clarithromycin based regimen. But what the problem occurring in day-to-day practice is they're not testing for the remission also. After treating for the H. pylori, after 1 month, you need to test the patient with a non-invasive test whether this patient has been cleared off from the H. pylori or not. So you need to use this particular regimen, which is my personal favorite. The next favorite is the levofloxacin-based regimen. There is another regimen called concomitant regimen. The concomitant regimen is actually a 4-drug regimen, but without bismuth. Here they are using 3 antibiotics, that is the amoxicillin, the clarithromycin, and the tinidazole with omeprazole. There is also a sequential therapy also. Sequential therapy here is 7 days regimen followed by 7 days regimen. In this 7 days regimen, they give 1 PPI with amoxicillin. Then they give PPI with amoxicillin with metronidazole. So you can use a sequential therapy also, although this is not a first-line therapy. The first-line therapy, according to the FDA, is the triple drug regimen containing the clarithromycin. But the clarithromycin is a very drug which can have a non-response in your patient. So nowadays, the 4-drug regimen is the drug of choice, that is usually containing bismuth thing. If you don't want to use a bismuth, you can have a 3 antibiotic regimen called concomitant regimen, and the levofloxacin-based regimen, that is the omeprazole, the amoxicillin, and levofloxacin. The other drugs which can be used are the rifabutin. There are rifabutin-based regimens are also coming for the H. pylori. So the newer drugs can be the rifabutin. This can be the entrance question. Again, if you are not seeing any response for the patients, you can consider for the culture-based testing also. So what does the guidelines say? The first line, if the clarithromycin resistance is low, you can use clarithromycin-based therapy. If the resistance is very high, you can use a quadruple therapy, either a bismuth containing or a non-bismuth containing quadruple therapy. So non-bismuth containing quadruple therapy is usually a concomitant therapy where we use 3 antibiotics, that is the amoxicillin, metronidazole, and tinidazole plus omeprazole. And if there is no response for the first line, obviously the levofloxacin-based regimen is the second. And the 4th line is the rifabutin therapy. And even if the rifabutin therapy is not working, you can go for a culture-based therapy. So this is what the basic funda is. Don't use clarithromycin in India. Use bismuth-containing therapy. If you don't want bismuth, use a quadruple regimen containing concomitant therapy, or use a levofloxacin therapy. Even the levofloxacin resistance in H. pylori is also increasing nowadays. So this is a Harrison table. So indication for H. pylori, you need to know it is a peptic ulcer disease or an old or a new, you need to test. The maltoma, you need to test and treat. If the early carcinoma who has undergone the gastrectomy, you need to test. If the H. pylori is negative, then H. pylori is not the cause. If the H. pylori is positive, consider the first line therapy. So the first line therapy in clarithromycin resistant, it is OBTM. In clarithromycin sensitive, it is OCA or OCM. So give it for 14 days. After the end of this treatment, wait for 1 month. After the 1 month, get the non-invasive test. You can get either a breath test or a stool antigen test. So if it is negative, then yes, your treatment has worked. So no remaining symptoms, you need not worry about the H. pylori. But if it is positive, if it is still positive, then consider the second line treatment. If the second line treatment ends, then wait for 1 month, again test. If it is still positive, then consider third line therapy. or you can consider the antibiotic sensitive testing according to the antibiotic resistance pattern, or you can consider for the early referral to the concerned specialist. So this is in particular about the H. pylori. So in this particular slide, I have also given the important slides pertaining to the acute infectious diarrheal diseases, which are must to revise before going into any entrance exam, because the standard questions, especially the types of the acute infectious diarrhea, how the treatment is going on, what are the complications of acute infectious diarrhea is being common, traveler's diarrhea, what are the organisms, what is the most common organism, and what is the treatment of traveler's diarrhea, what is the bacterial food poisoning according to the duration, the complications of this inflammatory diarrheas, and some questions I have given. So you can get back to me if there is any doubt regarding this particular things. Thank you very much. Next thing we will try to deal with the infections in a organ transplant recipient patient. Thank you.